to get started?
Sure, I can definitely do that. So the paper that we are talking about really focuses on patients with brain metastasis. And the brain actually represents one of the more common sites for disease to metastasize to. And as a consequence, the total number of patients afflicted by brain metastasis is actually very large. We don't have exact numbers because although cancer is a reportable disease, the specific occurrence of metastasis within any given organ systems is not a uniquely reportable event. And therefore, what we have at best are estimates. But current estimates suggest that annually in the United States, maybe up to 300,000 patients might develop brain metastasis. In some cancers, these occur late in the natural history of the disease, many months or years after the original diagnosis of the cancer. Breast cancer is a very good example of that. In other cancers, brain metastasis can occur early, within weeks or months of diagnosis of the primary tumor, sometimes at the same time as the primary tumor is diagnosed. And lung cancer represents a pretty good example of this second situation. Now, historically, the approach by most oncologists to patients with brain metastasis has been very nihilistic. And there were some good reasons for this nihilistic approach. Overall, the survival of patients with brain metastasis historically was very, very poor. In the remote past, the median survival, the average survival, was only about 3 to 6 months. And secondly, the majority of patients with brain metastasis could not effectively be treated with any of the drug therapies that we had because the drug therapies could not penetrate into the brain in sufficient quantities to be effective. So when patients with brain metastasis would present, the dilemma was that you couldn't really use most systemic therapies, and their survival was very poor. So not uncommonly, many of these patients would be treated in a very palliative manner. They would be referred to hospice. And in general, clinical trials would exclude patients with brain metastasis. The reason for doing that was because if you're testing a new agent in a clinical trial, and if your patient has a low likelihood of surviving beyond a certain number of months, you would not get the information about the drug that you're testing. And so many of these patients were excluded. What we reported in the JCO publication was a very large database analysis of approximately 7,000 patients whose data were collected rigorously from 18 different institutions from 3 different continents. So this was actually a database collection. Each institution enrolled specific data that were IRB approved and that were team evaluated and team peer reviewed into a centralized database. Over a period of a few years, we have published a variety of reports from this database that focused on different subsets of patients with brain metastasis. This particular report is an amalgamation of the entirety of the information in the database of 7,000 patients. And the key things that we observed in this database, which is a living document, it continuously gets updated on a regular basis as new information comes in. There were a few key observations that we made in this particular publication. The first was the observation that survival has in fact improved in patients with brain metastasis. So overall, that's good news. The median survival has improved compared to what we used to observe in the past. But perhaps even better news is the fact that there are subcategories of patients that have substantially better survival. We're talking now survival in years as opposed to months, which was very commonly observed in the past. So now we know that subsets of patients do much, much, much better than we used to historically give them credit for.
And why is that? That's just by mere observation?
We think there are several factors that influence that. Okay, and I'll get into that in a minute. But the bad news is that there are still some subsets of patients whose survival is not that good. It is still measured in months. So now what we are seeing is a heterogeneity in terms of outcomes, with some subsets of patients doing much, much better and some subsets not doing so well. And so a key take-home message from this is that it's not appropriate to categorize a patient with brain metastasis as having just one outcome, that this patient is going to have a bad outcome, because many of these patients might have a significantly more favorable outcome. If one knew ahead of time that a patient was going to have a better outcome as opposed to a worse outcome, the perspective and the approach to managing that patient might be very different than the perspective and the approach of managing a patient whose outcome one might not be able to influence.
Right.
For example, there is no good reason why many of these patients who have survival that can be measured in years should be excluded from clinical trials. So the paper that we published now allows us to determine a number known as an eligibility quotient. And this eligibility quotient would tell us, here's a patient that is likely going to have good survival versus a patient who is not. And therefore, if you have a trial of a new agent, it is very reasonable to include a patient with good survival probability in such a trial. So options improve and open up for these patients for clinical trial enrollment.
Got it.
This is particularly useful because a lot of the newer systemic therapeutic agents do now actually penetrate into the brain. The brain is protected by a barrier known as the blood-brain barrier, and historically most drugs were kept outside the blood-brain barrier. But we now have drugs that can penetrate the blood-brain barrier, which means these patients can access agents that are potentially active in the brain. And of course, if these agents work against the brain metastasis, they would likely have an impact on the outcomes of these patients. So that's why allowing these patients to go on clinical trials is so important. Now, you asked the question, why some patients do better and others not so well. So we asked the question, what are the factors that drive that? And in the remote past, we used to lump all brain metastasis patients into one group, whether they had brain metastasis from lung cancer or breast cancer or kidney cancer or melanoma or whatever it was. We would lump them into one group. And we would have a few predictive variables, we call these prognostic factors, that would tell us which patients would have superior survival. Now, with this 7,000 patient database, what we have learned is that we can create a much more sophisticated model. So we can break patients down into different categories: lung cancer patients, melanoma patients, breast cancer patients, etc. And within these histologic categories, we can have subtypes of patients based on specific variables for each disease. And that's what allows us to create this grouping, which is known as the Graded Prognostic Assessment, or GPA grouping. Your image is frozen, Patsy. I don't know if you're there or did I lose you?
We may have lost her.
Yeah, I think we lost her. I'm sure she'll try and come back on.
Yeah,
Okay.
please continue, Doctor.
We're still with you.
Yeah, we're
Yes.
still with you. Don't worry.
Sounds good, okay. So, as I was mentioning, these prognostic factors have now become much more refined. So within each disease category, we now have prognostic group, as opposed to just global prognostic factors for patients with brain metastasis. We can now predict the survival of a given patient, which allows us to develop an algorithm or a tool into which we can input data. So when we see a patient in the clinic, we can input the various parameters of the disease and the patient into a calculator. This calculator has now been turned into an app, which we have posted online, so any clinician anywhere in the world can access it. And by inputting the patient's data into this calculator, we can have a reasonably good estimate of the predicted survival of a given patient. This information is very useful when discussing things like prognosis with a patient. It's very useful in discussing things like clinical trials with a patient. It's also very useful for patients to have this information because they can make decisions about how they want to approach the management of their disease. So the graded prognostic assessment, or GPA, which is scored like a GPA from 0 to 4. So a patient who has a score of 4 would have significantly better survival than a patient with a lower GPA score. This allows us to have an informed discussion with the patient and the family about their options and what can be done going forward with the management of their disease. So these were some of the key findings of the paper. What we did learn is that certain diseases remain difficult to take care of. So, for example, patients who develop brain metastases from gastrointestinal tumors, tumors of the gastrointestinal system, still continue to have significantly worse survival than patients with brain metastases from other diseases. So we still have significant room for improvement, and although we've seen improvement in survival, the scope for improvement with the newer agents is still considerable. And that's why identifying patients who could get onto clinical trials of new agents is so crucial, because it becomes a self-fulfilling prophecy if we start by assuming that these patients are going to have poor survival, and therefore we don't enroll them on trials of agents that could be effective in such patients, and then these patients have poor survival. Instead, if we recognize that some patients can have better survival, and we enroll them on these trials, we might find agents that are effective. Of course, what's important is to recognize in any clinical trial that we have to stratify the clinical trial. Because patients with brain metastases have different survival rates, some patients have better survival, some not so good. We have to have different categories or different bins of patients in these trials, and we call that process stratification, and that balances the risk variables on the different arms of a clinical trial. So those are some of the key findings of this particular paper. I don't know if you want me to address anything else.
Yes, we have some more questions, but that was great. Thank you for that background. And by the way, I don't know if you noticed, but I'm sorry, I lost my video connection, so that's why you don't see me on the call, but obviously I'm here on audio.
Okay.
No, that's great. I
out.
do have, I dropped out, but I'm here. So I do have some questions for the good of the group that I'd love for you to just say out loud for those that maybe don't have all the information. What is the name of the peer-reviewed journal?
It's called the Journal of Clinical Oncology, or JCO.
Perfect. Okay. And when was the paper accepted for publication?
I have to look that up to give you the exact date, but it was accepted for publication on August 15th.
On August. Okay. And then when did it publish?
It was published on September 15th.
Perfect. Okay. So just a side note, Aaron, you see how there's a lag time. So we're trying to figure out, just moving forward also for us, like for PR purposes, when is the best time to have these insight calls? in hindsight, I think it's good to try to connect with you or any of our researchers when it gets accepted for publication, so we can kind of be ahead of the ball. Because it looks like they give you, after they accept it, correct me if I'm wrong, Dr. Mehta, they give you a few weeks before they publish. It's not like it publishes right away.
Correct.
Okay, that's good to know. And then it published in September. Okay, that's great. I have some questions I'd like to go over that are kind of our standard questions that help us gather our thoughts in an organized manner, but I think you've answered a lot of them. So please, if you feel like you've already answered the question, feel free to say, I've already addressed this, but I'm just going to go through it just to help us kind of, like I said, organize our notes a little better.
Sure.
So the top 5 takeaways in layman terms. And when I say in layman terms, Dr. Mehta, and I think you've already said a lot of the key takeaways, but if you can kind of give it one more shot in a more summarized way and speaking as if you were talking to the patient or to the patient's family member, the takeaways of what you discovered or of the study.
Right. I think the key takeaway messages are the following. Brain metastases remain a common and clinically significant problem in many patients with cancer. Although historically the survival of patients with brain metastases has been poor, recently we have seen improvements in patients with brain metastases. And in particular, there are certain subsets of patients in whom survival improvement has been substantial and dramatic. We can identify who these patients are using an algorithm that takes into consideration clinical data relevant to the tumor as well as the patient. And that means we can individualize our predictions about survival in patients with brain metastases. This allows us to access information that's useful for decision making between the physician, the patient, and the family about treatment options, as well as the opportunity to be considered for enrollment on clinical trials. And if such a patient is enrolled on a clinical trial, the knowledge of different rates of survival between different subgroups allows for what is known as stratification within a clinical trial, which means that appropriate balancing of the arms of the trial can be performed. Those are some of the key take-home messages.
That's great. And would you say that in terms of the key benefit to the patient, is it in a way, is it essentially that they are now have hope and have the hope and the possibility of access to innovative medicine through clinical trials that in the past they may have not had access to? Is that accurate to say that?
That is definitely one benefit for patients. In this context, one can view information as power. Information gives you the power to make decisions that reflect reality. They also give you hope. They also give you the ability to have a very honest discussion about what one's goals are regarding the cancer treatment. So patients can choose, for example, more aggressive therapies if they expect to have longer survival. They can choose and be eligible to go into clinical trials if their survival is longer. If their survival is unfortunately not good, they may choose a more conservative approach and decide that quality of life is a much more important endpoint than an aggressive approach to treatment. So at both ends of the scale, the information has value in decision making. And of course, that decision making is a joint process between the patient, the family, and the clinician.
And they're able to make these decisions moving forward because of this new innovative app.
Right, so the app is just an easy way. So one can go through the paper, and for each type of disease that produces brain metastasis, one can compute the predicted survival by going through the algorithm, which would easily take an hour or more to do. Or you could just download the app on your phone in the clinic, and even before you see the patient in the clinic, you can input the clinical data from the patient's medical chart into the app, and that way you would have an estimate of the expected survival.
And Dr. Mehta, what is the name of the app? Yeah.
I'm sorry, I didn't hear the question.
Dr. Mehta, what is the name of the app, and where can you find it?
The app is known as BrainMet GPA. So it's all just one word, BrainMet, BrainMet, Met, GPA. And the GPA stands for this graded prognostic assessment, which is the score that a patient gets assigned. One can go to any online app store, and it's easily searchable and downloadable on any smartphone or any handheld device.
Did you develop the app? Mm-hmm.
I'm sorry, there were two people speaking at the same time.
Sorry, go ahead, Erin, go ahead.
Sure, just one last question related to the app. Is if you developed the app, or did you work with a team? Just who spearheaded this effort?
So this is a collective effort from 18 institutions, and so no one individual can claim credit for this work. I am the senior author on the paper, so I helped lead and guide the team that did the work. But this was really collective work from several authors from 18 different institutions from 3 different continents. And the app is freely available. There's no proprietary restriction for the app.
Dr. Mehta, so just to be clear, so this app did not exist prior to.
Correct.
Part of this research study, part of the development of it is this app. I mean, that's part of the discovery, or what would be the right term to say this? Because this is not a new treatment, is it? What is the right way to term this? This is a new discovery? How do you refer to this?
Right. So this is a paper that evaluates the outcomes of patients with brain metastasis in the modern era, identifies the variables that can predict survival for a given patient, provides information that is extremely useful for decision making.
Right, it's a resource.
And this information is quite accurate, it's very accurate, because one doesn't have to speculate or guess, and one can simply use an algorithm to make the prediction. And given the fact that we can take algorithms and convert them into apps, this is essentially available to any clinician, in their pocket, on their smart device. So
Perfect.
It allows for a robust and accurate discussion of options between a patient and a clinician in a matter of minutes.
Perfect. That's amazing. That is amazing. And your role is, so we would not say principal investigator? That's not the right term.
I think the most accurate term would be senior investigator.
senior investigator. Was there a principal investigator in a big study? Is there a principal investigator in a study like this?
Usually not. A principal investigator is a title that's used in a clinical trial. This is not a clinical trial. This is a database analysis. So
Got it.
there's a difference between a
Got it.
database analysis and a clinical trial. But there,
database analysis?
the equivalent to that would be what you would call the first author, right? So the first author is a physician called Paul Sperduto, who works in Minneapolis. And so he's one of my colleagues, and he and I have been working on this project for quite some time.
Got it. I could imagine. I mean, and out of it came this innovative technology, this app that is now a resource to patients and oncologists around the world to help
Exactly.
predict survival.
Yes.
I'm sorry, Papsi. I have a quick question. Dr. Mehta, the
Yes.
app, the patient themselves cannot manipulate the app and get their number, correct? It has to be done by a
can.
clinician?
They can. Anybody can. Okay.
Just
Because
the
it's an
patient-
app. So you can download the app
Uh-huh.
and you can input the data. Now, some of the data are medically oriented,
Mm-hmm.
but a savvy patient can figure their way around them.
Okay, I didn't know if they could do it on
Yes.
their own or it had to be in conjunction with test results and
No.
things.
Yes, you do need test results.
Mhm.
So as long as a patient has access to some of the
Okay.
test results, they themselves could input the data
Wow,
to
that's
figure it
excellent.
out. Yes.
That's excellent. Thank you so much.
That's amazing. The original question was what did treatment look like for patients, but I guess it wouldn't be treatment in this case. Like what does it look like without this resource for a patient typically?